Thank you. Thank you, everyone, for being here and being still awake after such an intense day. And we're commenting, we have 3 Italians in this session. So probably the espresso will float in the air and keep everyone awake. Anyway, so we're going to talk a little bit about synucleinopathies in this session, and I'm going to start with multiple system atrophy. What's multiple system atrophy? Well, it's Parkinsonism or cerebellar ataxia associated with autonomic failure. Other synucleinopathy include, of course, diffuse Lewy body disease, which is characterized by dementia, Parkinsonism, hallucinations, REM behavior disorder, autonomic dysfunction, which is less severe than in multiple system atrophy. So that's usually, it's a differentiating features, particularly at the beginning when you're not sure sometimes which direction the patient is going to go. And then, of course, Parkinson's disease, in which autonomic involvement is generally the least severe of the 3. They may have some dementia, and they are the one that, of course, respond the best to levodopa. There is also pure autonomic failure, in which there is no motor involvement, but it's a selective autonomic problem. But as you'll see in a little bit, some of these patients will evolve eventually into multiple system atrophy. And one of the key is to try to see if we can identify which patients are at higher risk. The consensus criteria, this was the second one. Actually, this was the first one. The second one is very similar anyway. For multiple system atrophy, we'll not be laboring it too much, but basically, you needed to have significant autonomic involvement, defined as either neurogenic bladder or documented orthostatic hypotension. And then, to make it probable multiple system atrophy, you need to have Parkinsonism or cerebellar dysfunction. Obviously, there is no definite unless you have autoptic proof, so that doesn't help much the patients when they are alive. The probable one, they may have Parkinsonism or cerebellar dysfunction, and at least one component of autonomic involvement that, however, is not severe enough to make it probable. So the findings are present but less severe, and they must have one of the additional features, such as stridor, the poor response to levodopa, et cetera, that you see listed here in this paper of 2008. I don't know how well it projects, but basically you needed to have some clear documented motor dysfunction with some atypical features, some abnormalities on PET studies, etc. So if you have at least one additional of these features, then you make the diagnosis as probable. There are features that clearly support the diagnosis, so when you find it, you should really raise your antenna and think about multiple system atrophy, such as presence of orofacial dystonia, anticolis, camptocormia more severe than expected, the PISA syndrome, contractures, some stridor, or this very characteristic inspiratory size that the patient seems to have frequently. They may have dysphonia, dysarthria, again, out of proportion to the degree of motor involvement, cold hand and feet, pseudobulbar affect, sometimes myoclonic tremor. If you see the classic P-rolling tremor, usually that excludes the diagnosis, so that should make you think that this is not multiple system atrophy. Clinical significant neuropathy usually makes you think of something else. Hallucination not induced by drug, again, doesn't usually support the diagnosis of multiple system atrophy and should be a flag. Also, onset in very old age, it's unusual. Family history should, again, make you think of something else. And, of course, other pathology is excluded. What's the prevalence? Well, the only real study that looked at this is pretty old still. And the prevalence is pretty low overall, so 4.4 per 100,000, with the 2/3 of the patient being Parkinsonian and about a third cerebellar presentation, and then the rest is mixed. And eventually, as the disease progresses, the patient will have both aspects. Parkinson's disease is a lot more common. So if you see patients that, again, may present with some atypical features, still, just by sheer chance, they may still be a Parkinson patient with some extreme features. So keep that in mind. Obviously, it's a sporadic, progressive, fatal multi-system neurodegenerative disorder, and these are the key features that you must have in order to diagnose it. The progression is unfortunately relentless, and the survival on average is less than 8 years from diagnosis. The prevalence already, as I said, and varies a little bit depending upon patient population studies. The autonomic failure usually occur early in MSA with rapid progression and can be the presenting features. There are other components, as we mentioned, that you see very often in multiple system atrophy that you cannot ignore because, first of all, can have an impact on the quality of life, and second, can actually have a direct impact on their survival. A lot of sleep problems have been described in multiple system atrophy: insomnia, restless leg syndrome, central hypersomnia, parasomnia, and breathing disorder. The probably most problematic that you needed to manage is REM behavior disorder. I have patients that eventually end up in sleeping in a bedroom that has been emptied of everything. They just have a mattress on the floor so they don't injure themselves or others. Treatment otherwise at beginning, melatonin or clonazepam. Breathing disorder, very important to recognize the presence of stridor because patients will otherwise die in their sleep. And the treatment will be with CPAP or eventually BiPAP, and they may need a tracheostomy by the time they reach stridor. They also will have hypersomnia as well as insomnia that need to be treated, and those can be variably problematic for the patient or not. Restless leg also very, very common, and the treatment is a standard with iron, gabapentinoids, or dopamine agonist medications. This is classic image of a patient with REM behavior disorder. You'll see the lack of loss of muscle tone during REM sleep, which again implies the brainstem dysfunction. Speech involvement is also extremely problematic and very frustrating both for the patient and their family. Dysarthria. You can have almost any combination in multiple system atrophy. You can have the hypokinetic, the spastic, and the ataxic, and in any combination. You may have all three. Hypokinetic is probably the most common, but again, as the disease progresses, they evolve and accumulate the other ones, so making the speech therapy even more challenging, and that's very important to have that addressed. With that, they also have dysphagia, and the problem swallowing. That's common in Parkinson, but again, in this patient, always it's a notch higher in terms of degree of severity. So they start with problem handling their secretion, liquids, then solids, and medications. Common symptoms which are also present in Parkinson, the drooling, the prolonged chewing, etc. Eventually, most of these patients will need a feeding tube. Bowel, most common problem is constipation, and the management is usually with dietary changes as well as Miralax. Oh, what did I do? I'm not sure. Sorry about it. Glycerol suppository or clonidine, and bowel preparations, and bowel, again, treatments. You can also have diarrhea, and make sure that this is not due to an overflow, due to the obstruction. You can try to add occasionally an anticholinergic agent, but that usually worsen a lot of the other autonomic problems. So usually it's much better to manage it non-pharmacologically as much as possible, having made sure to exclude the overflow from obstruction and obviously bacterial overgrowth. Bladder, we talked about the problem of neurogenic bladder being actually one of the key diagnostic criteria for multiple system atrophy. There are quite a few bladder centers, actually 5 to be precise, and they are all involved in multiple system atrophy. Now, what kind of problem can the patient experience? Well, the bladder really can only do 2 things, storage and then has to empty it. So you may have a problem with either one or a combination of the 2, which obviously is the most problematic. You need to make sure the patient doesn't have post-voidal residual. Urgency is probably the most common problem, and these are a list of medications that are used. Unfortunately, most of these medications can worsen orthostatic hypotension, so you have to be really careful in managing this patient with that. How about if the patient has retention? Again, same problem. Patient can try alpha blocker agents, but that can worsen the orthostatic hypotension as well. And eventually, most of these patients anyway require self-cath. And again, there are both a central and peripheral mechanism that can contribute to these symptoms, and that's why they're also so difficult to manage. You may try to treat the urgency, and pretty soon the patient develops retention, and the other way around. So very, very challenging. And again, constipation can be seen early and can be very severe, both in central as well as in peripheral autonomic disorder. So how do we recognize multiple system atrophy when they are at the very beginning? It's very easy to recognize it when the patient is pretty advanced and it's in full blown. But how about when you have a patient and you don't know if it's early Parkinson's disease, early MSA, or whatnot? Another problem that we have been having as part of, in our autonomic clinic, is seeing patients with pure autonomic failure or presenting with symptoms that look like pure autonomic failure, and then the patient comes back a few years later and they have evolved into multiple system atrophy. We have done different studies looking at this, and basically the finding, you would think, for instance, that REM behavior disorder will be the biggest predictor. Well, it's not. The one that clearly points to a higher risk of conversion is the presence of severe bladder dysfunction at the onset or at the presentation, that the patient has a higher risk of evolving into MSA, or if they have supine norepinephrine baseline when they are supine at greater than 100 picogram per ml. In pure autonomic failure, usually they are less than 100. If they are above 100, they probably will evolve into multiple system atrophy. And we have this CAS score, which is an autonomic score we do when we test patient in the lab. If the patient has more severe score there, they also will predict to multiple system atrophy, but not necessarily. How is the survival for multiple system atrophy? Well, Dr. Kuhn, I think a couple of years ago, don't remember exactly the date, looked at patient with the Parkinsonian variant or the cerebellar variant, see if there was any difference. There isn't. The curve is the same. And again, about 50%, again, the magic number is still 8 years. Do we have patients that survive long? Yes, they're rare, but occasionally you have the rare patient that beats the odd. But still, unfortunately, it's a pretty severe condition, and we are still struggling with treatment, needless to say. Other risks of a worse or a faster progression, besides the bladder, which was again the factor that you predicted that from pure autonomic failure will convert to MSA, is the presence of falls within 3 years from the onset. That usually portend a poorer prognosis. Also, poorer prognosis is the presence of need for catheterization, urinary catheterization within 3 years. Again, so neurogenic bladder is really a very important parameter. Early orthostatic intolerance, the total score of the autonomic dysfunction, which shouldn't be a surprise, and the age of onset. So all these are portend, again, a poorer prognosis. So what's the pathogenesis of MSA? I'm sure you've heard a lot in this meeting so far about synuclein. And at the end of the day is we have this monomer, becomes an oligoburn, then protofibrils, then fibrils, microglial activation, inflammation, toxicity, oxidative stress, cytokine, glial, and neuronal pathology. So the characteristic hallmark of MSA is the inclusion in both the glial as well as in the neurons. And the areas affected include the striatum, the cerebellum, the brainstem, cortex, and spinal cord. And actually, probably the first site is the brainstem, and that's where a lot of the symptoms really localize, if you think about it, with the sleep disorder, the breathing abnormalities, etc., etc. Again, these are Lewy body on the left and glial cytoplasmic inclusion on the right. One of the biggest challenges has been finding biomarkers for multiple system atrophy. And one of the reasons is to see if we can identify patient earlier. Now, do we have, obviously, a cure? No, not yet, but we're hoping to have one, hopefully not in a not too far future. So you don't want to treat patients when they're too advanced. And one of the questions, whenever there has been the therapeutic trials that have failed, there's always been, are we missing the window of opportunity? Are we catching the patient too late? And so the treatment that seemed to be promising on animal models and whatnot doesn't work on humans. We have obviously the luck at Mayo to have a very extensive autonomic testing capability, but that's not widespread everywhere. And we are really looking at biomarkers, particularly in the spinal fluid, and we're working on it, and I think other people are working on it, so hopefully something will come out reasonably soon. Imaging, well, there is a typical hot cross band sign in the brainstem, but that's overall fairly late in the disease, so it doesn't really help you too early. There are newer techniques that are being developed to do quantification of the areas that are mainly affected, sort of basically doing a radiologic BRCA criteria, if you want to put it that way. I guess, is in the works, so stay tuned. Hopefully we'll have some data available soon. Just a couple of images, because it's always nice to show images. This is a tilt study of a patient with multiple system atrophy. In red, we have a systolic blood pressure. In yellow, the diastolic. In green, the heart rate. At this point, the patient is tilted up, and you see a profound orthostatic hypotension. However, the patient still manages to stay up for about 5 minutes, despite the fact that the patient has severe orthostatic hypotension, no cardiac responses. So you may wonder, why is that? Well, the patient adapted to his condition by developing supine hypertension, which is obviously a compensatory mechanism, not great long-term because that caused a lot of other end organ damage, but it's the only way that this patient can function for a while. And also they have expanded cerebral autoregulation, so even with low blood pressure, they can oftentimes maintain enough cerebral blood flow to prevent syncope. This is an image of a thermoregulatory sweat test. This is a very messy test. The patient is dusted with a powder that changes color from yellow to purple from dry to wet. Then we dust the patient, We put the patient literally in an oven with a temperature of about 48 degrees Celsius at about 30% humidity. And we raise the core temperature of 1 degree or up to 38 degrees Celsius, whichever is highest. What do we see in patients with multiple system atrophy? This kind of pattern. Basically, they look like I have a purple glove and purple socks on. So exactly the opposite of what we usually see in patients with peripheral neuropathy. They have a glove-stocking distribution, loss of sweating. Here, the loss of sweat is more central. So anyway, when we see this, we pretty much can call it. Other things that you can do to test this patient, again, this is a lot of work that Dr. Goldstein had done. Catecholamines in synucleinopathy, plasma level. Metabolites of norepinephrine seems to be more sensitive. They are generally decreased in Parkinson with orthostatic hypotension, pure autonomic failure, and multiple system atrophy actually is generally normal because it's a preganglionic disorder. So that's something that we use in our testing. We don't measure the dehydroxyphenyl glycol. We just measure norepinephrine in the plasma. It's not super sensitive, and you need a good assay. But again, it's usually very abnormal in the peripheral syndromes and is normal in multiple system atrophy. How about in the spinal fluid? Same concept. These are controls. And this time, also the multiple system atrophy group is decreased. Parkinson disease less than controls, but is the least affected, the multiple system atrophy. And again, pure autonomic failure is the worst of the worst in terms of drop in catecholamine and its metabolites. How about functional imaging? If you do cardiac functional imaging with MIBG, etc., you find abnormality if you have a peripheral cardiac denervation, so again, diabetic autonomic neuropathies or peripheral autonomic disorder, pure autonomic failure, Parkinson disease, but image is normal in multiple system atrophy. So that is something, again, can help you differentiate between the two. How about fluorodopa PET or DAT scan? Again, abnormal in Parkinson disease, not abnormal in pure autonomic failure and MSA. So all these are supporting evidence. This is just an image of patient cardiac scan, normal patient, pure autonomic failure. Again, you lose the image in the heart. Multiple system atrophy, the image is normal. Parkinson disease, the heart disappear. Again, postganglionic pathology. How about treatment? Unfortunately, it's only symptomatic, at least for the moment. Levodopa therapy, we usually say patients do not respond to it. In reality, they may respond. They never respond as well as a Parkinson patient. And the response is usually transient and furthermore may worsen the orthostatic hypotension, so we need to be careful with that. So you need to work on managing orthostatic hypotension, and I'll talk about that in a minute. Management of neurogenic bladder and bowel, I already mentioned that. Tracheostomy to prevent death during sleep, manage the REM behavior disorder, and very aggressive physical therapy, speech therapy, occupational therapy, as well as work with your GI colleagues to manage the nutritional status and eventually, again, the feeding tube. So orthostatic hypotension is probably the most problematic from the autonomic symptoms. And if you like ABCD kind of mnemonics, look at the paper by Dr. Figueroa I did a few years ago. So the management, you start always with non-pharmacological option first. Abdominal binder, increase fluid, increase salt, elevate of the head of the bed, work with physical counter maneuver, and then medications. Well, we don't have a huge amount of meds. Fludrocortisone, it's a volume expander. Pyridostigmine enhances ganglionic transmission. Not super powerful, good at the beginning, and good as a midodrine or droxidopa sparing agent. And then midodrine and droxidopa are the two most specific and actually the only two FDA approved for orthostatic hypotension. Very important to educate the patient to recognize symptoms of early fainting so they don't crash to the floor, and fluid and salt as mentioned. A lot has been said sometimes about the issue or the effect of levodopa. And yes, levodopa can indeed induce a drop in blood pressure. Most patients with Parkinson's disease have no problem with it, but if you already have a propensity to that, you may tip the patient over the edge. So you need to be very, very careful with that. How about treatment? Well, I'm not going to spend a huge amount of time on all this, but basically the concept of everyone is now targeting the alpha-synuclein and say, okay, how can we stop it? So there are antibodies that people are trying to develop. You try to reduce the production, try to improve clearance. I don't think this is legible, probably. Anyway, so the idea is, again, what can we do to prevent the deposition of alpha-synuclein? And I think there were some presentation already about monoclonal antibody, anti-RNA, oligonucleotides, etc. So we'll see where this goes. We're still at the beginning. If you look at the trials that have been done so far for multiple system atrophy, you can say the usual everything but the kitchen sink has been thrown to this patient. And unfortunately, none of this drug has worked. I mean, none of this trial has been effective. There's been some preliminary data that seem exciting. Then you go further and, well, the benefits seem to disappear. Probably the most promising that we had more recently was the study that was done by Lee and colleagues in 2012, stem cell. This was the first study with infusion actually into the carotid. And I really applaud those guys to being so brave, because I would have been scared to death of causing stroke. Anyway, they seem to show some slowing of the progression in the treated patients. So where do we go with that? Well, Dr. Singer et al. And Mayo have been running a study, and they're still in the preliminary phase, basically doing a dose escalation trial. And this time, instead of delivering it into the carotid, we are delivering it intrathecally. Primary endpoints were frequency and type of adverse event. Again, this was also a safety and tolerability study. And secondary endpoint were the rate of disease progression assessed by the Unified MSA Rating Scale and indices of autonomic function. So this is the preliminary data that I can show you. It was actually presented a few months ago at the Academy. 24 patients enrolled, follow-up 1 year so far, no serious adverse event reported. At the highest dose tier, though, 3 or 4 patients developed low back and thigh pain associated with thickening and enhancement of the lumbar nerve roots and variable elevation of the CSF protein and cell count, but there were no neurologic deficits. The rate of progression was markedly lower compared to the placebo group, with a P of 0.009. The difference was more pronounced for the medium than the low dose, so there seems to be a dose effect. The study is still ongoing. We're hoping we can get funds to continue it further, because again, we were actually quite encouraged by this preliminary data, so stay tuned. And with that, I think my time is up. And thank you for your attention.